Hello, everybody. Thank you for coming. There's a couple quick announcements before we start today. The first is make sure to follow us on Instagram to get all the updates. Join our email listserv on our website. We're going to drop that link down below. Make sure also to follow us on LinkedIn and list us as one of your experiences. And all the links for that are also in our Instagram bio and our Linktree. So if you need any of those or the quiz form for today, it's going to be in the bio as well. Other than that, without any further ado, we'd like to introduce our presenting physician, Dr. Hughes.
All right, thanks so much. Thanks for having me today. Hi, everyone at home. We're going to be talking today about what it's like to be a pediatrics resident. I want this to be as interactive as possible given the platform. So please, if you have any questions, type them in the chat box. We'll have the Shellcast crew read them out to me. And let's have some fun tonight. Okay, I'm going to share my screen. Okay, how are we doing? So far, so good, guys? Excellent. Okay. Like I said, my name's Rachel. I'm a current second year. Before we get started, just because I just have to say I'm not getting paid or anything like that. I'm going to talk about some cases. None of them are real patients. None of the photos are my real patients. And everything I talk about today is my opinion and not that of my school or my employer. Okay. So about me, my name's Rachel. I'm a second year in a pediatrics residency, and that's 2 out of 3. So I'm more than halfway done now. I currently work at both NYU and Bellevue hospitals. The residency itself is through NYU, but we do half of our time at Hassenfeld Children's Hospital and half of our time at Bellevue. So it's a really cool mix. We get to see a wide breadth of cases, and it's been really awesome working at Bellevue, which is a public hospital in New York City. Where I went to school, NYU for undergrad as well, and then I went to med school at Pitt. Other things I like to do besides medicine, baking, cooking, and I'm currently planning my wedding, so we're quite busy these days. Just a little bit about the field of pediatrics in general. So what is it? We care for infants, children, and adolescents in all aspects of their health. This is their physical health, their mental health, emotional health. We get involved in their school and their families and their communities, and even in the kind of the legal works that surround caring for children. We care for babies from the second that they're born until they become adults. It varies depending on what hospital you're at. At Bellevue, for example, in the emergency room, we'll see someone up to 25 years old. So that's, maybe some of you guys would be able to come to the PDD. Other hospitals, once you turn 18, you go to the adult service. And then here I mentioned sometimes even prenatally. For example, if we know a woman is pregnant and the baby's, 23, 24 weeks, and the woman goes into labor, we get neonatologists, which is a field of pediatrics, and they can come and they can consult and speak with the woman about her options and kind of what's in store for her baby if they're born so prematurely. So we really have a cool, nice wide breadth that we care for. Here, I actually can't see my photos because my Zoom is in the way. I believe this is a photo of intubating a baby in the NICU. So here's an example of taking care of someone, the second they're born. In general, pediatricians or neonatologists are at deliveries, especially high-risk deliveries. We take the baby right from the OB-GYN physicians, and we bring them over. We make sure that they're adjusting well to extrauterine life, and if they need any help breathing, or if we're concerned about their heart rate, we have all kinds of interventions. So there's an example right from the second they're born. What kind of things do physicians in this specialty do? Literally all of the things, but just to name a few: preventative care, urgent or emergent care, inpatient, which is like your general pediatrics floor, as well as critical care, which could be the neonatal ICU or the pediatric ICU. We do some surgeries and some procedures, though if you want to be a pediatric surgeon, you do not go through pediatrics residency. Instead, you go through a surgical residency and do a pediatric fellowship. But we do some procedures, scopes and lumbar punctures and things like that. We have so many types of subspecialists. So for example, neonatology, or pediatric rheumatology, pediatric cardiology, pulmonology, infectious disease. Generally, anything that exists for adults, any specialty, we have that in peds, probably with the exception of geriatrics, which we of course don't have. And then pediatricians also play a big role in the community. So we are public health advocates if we're concerned about the safety of a particular child or maybe a group of children or a community of children. We do play a big role. We work with law enforcement, we work with politicians to make sure our kids are as safe as they can be. So this next photo on the right would be an example of maybe taking care of a patient on a general inpatient floor. You know, she looks like maybe she's in the hospital, but she's pretty well. And then here, this last photo would be someone in the pediatric intensive care unit. So he looks intubated, has tons of drips, all kinds of medicines. And we really do everything on this whole spectrum. And then just a little bit about my own focus. I'm a general pediatrics resident currently, but I am hoping to pursue a fellowship in pediatric hematology oncology. So that's going to be the study of blood disorders and of pediatric cancers. That is a 3-year fellowship, and then after that, I might even do an extra year in bone marrow transplant, but that remains to be seen. But hopefully one day I can look like this nice lady in the photo here. Okay, so a day in the life. I was asked to speak about kind of what it's like to be to work in pediatrics. And I also did want to shed light on what it's like to be a resident in general, even if you're not in the field of pediatrics. So I broke it down into sort of 3 settings. The first setting is clinic. So like I said here, it really varies. Your day is going to vary entirely based on what you go into, where you're practicing, and how far along you are in your training. But I'll speak as a resident. So if we're in our general outpatient pediatric clinic, that's where I am this month. I just got home from there. You know, maybe a typical day looks like this. So in the morning, you might have some sort of morning conference or morning report. This is where you'll discuss interesting cases or discuss new things going on in clinic, etc. You might see your morning, you might spend your morning seeing sort of general well patients, preventative visits. It might be their annual physical. They might be getting their vaccines. So they might look nice and cute like these little guys here. And in peds, we do like to be playful with our patients. So you can see he's kind of letting the patient examine him first. And that makes them a little bit more comfortable before we approach them. We do give vaccines. I will point out this is not the correct way to give a vaccine, so don't try to do it like that. But we do, you know, make sure our children are up to date on their shots, on all their blood work, on their school physicals. In the evening, you know, maybe you stay in your continuity clinic, or maybe you go to like a walk-in type clinic, like in urgent care. This could be for any need really that a parent wants their child evaluated for. So things like rashes, broken bones, vomiting, things like this. So here's a little one that you might see in your urgent care clinic. At the end of the day, once all your patients are gone, you will finish writing your notes, which sometimes takes longer than others. And then in general, I like to sort of look over who I'm going to be seeing the next day, just so I can prepare for clinic. When I'm in clinic, it's nice we don't work weekends. Most pediatric clinics are not open on weekends. Some may have some Saturday hours. And no pediatric clinics are open 24 hours, so you won't be doing any very long shifts as a resident. However, for example, this month, although I'm in the clinic during the day, on weekends I am covering the pediatric ICU, so I still have some weekends this month. But again, it all depends on where you choose to train and where you're at in your residence. Okay, sort of the next setting I wanted to discuss is what it's like on a general inpatient floor. So for example, for us, it's at our Hassenfeld Children's Hospital. The attending doctors are called pediatric hospitalists. That's their name. It's going to depend what time you get into work. I'm very lucky. My work starts at 7 a.m. A lot of other programs are 6 a.m., which does make a big difference, even if it sounds like it doesn't. So here in the photo, you can see two doctors. We call it sign out. It's a very structured way to convey patient information from the night team to the day team, so that nothing gets missed. After sign out, you do have some time. You can go over labs from your patients. You can go check on the patients that are sick. You may need to intervene on some, run some new tests, order some new medications. But it's generally a time to just sort of check up on everything and make sure everything's going okay. Most programs will have, again, some sort of morning report. This could be a case presentation about an interesting patient. It could be something called M&M, morbidity and mortality, where you talk about something that went wrong with a particular patient and areas for improvement. So that's most mornings. We have some sort of education. Then the majority of the morning is spent in attending rounds. And this I like to kind of describe as what you see in Grey's Anatomy. So here we have, maybe the resident. This is our patient and the patient's parents. Here's the big scary attending. The resident is presenting everything both to the parents and to the attending. The attending may have some questions or try to kind of test the resident's knowledge in a nice way. In pediatrics especially, you'll hear about stuff called family-centered rounds. And that means that it's very, very important for us to have the input and the buy-in from the patient's families. It's been shown that this, incorporating their feedback into our rounds makes families much more satisfied with their care and actually helps us deliver better, more efficient care to patients. Family-centered rounds is what that's called. Once your attending rounds are done, you just kind of take care of miscellaneous tasks for the rest of the day. That's going to be writing your notes. That's going to be admitting new patients, following up on labs. You may need to do procedures. You may need to do a lumbar puncture, etc. You're calling your consults. You're discharging your patients if they can go home. So your days can get very, very busy quite quickly. And then sometime around 6, maybe 7, the night team comes back. And again, you sign out to the night team. Let them know everything that happened that day and what the plan should be for overnight. Not all programs have a night team sort of schedule. I really like it because the Olive, instead of having 6 behind and works a 24-hour shift. So as you can imagine, that gets very, very exhausting quite quickly. So I much prefer having a night team. But as you guys, down the road apply to residency, that's something to think about. Do they have a night team or do they expect their residents to work 24-hour shifts? And in general, you will have to work nights and weekends of some kind. Okay, and sort of the last area that I wanted to talk about a day in the life is the pediatric emergency room, or the ED for emergency department. In general, these will be 8 to 12-hour shifts, depending on your level of training. They can be any time of day. They can be noon to midnight. A lot of times I work 8 p.m. to 8 a.m. It all depends on what schedule you got. You can see anything walk into your pediatric emergency room, especially us over at Bellevue with our, it's a big, big public city hospital. We get all kinds of things. It can range from a child who's perfectly healthy, but their parent is very, very concerned. For example, maybe this young girl is a healthy 4-year-old and she had fever one time. In general, that's not something that needs to come to the emergency department, but we do see this quite a lot. Parents coming with any sort of concern. They require a lot of education, a lot of reassurance and follow-up. You may see a healthy child that needs medical clearance. For us, this tends to be if someone is getting admitted to our psychiatric floor, they first need medical clearance that says that they're medically healthy to go to that floor. We also not infrequently get patients brought in by either the police or what we call ACS, which is like Children's Services. And they bring children in for medical clearance prior to placing them, maybe with a foster family or a new family. You'll see sick children that probably could have just gone to their pediatrician, but they do benefit from how quickly things move in the ED. We can get the medications faster, we can take x-rays faster, etc. You'll see sick children that need to be in the ED because they need immediate care or they need immediate imaging or labs or consults. So for this little one on the right here, you can see there's a pretty bad fracture in the tibia. So that would be something that we wouldn't want to manage just in the pediatrician's office. We would want to send them to the ED. Here we could make sure, there's no other injuries. We could make sure that their pain is appropriately treated. And we could call maybe the orthopedic surgeons to evaluate this patient to see if anything is needed. And then finally, of course, in the emergency room, we see true emergencies, critically ill children. They need stabilization. Maybe they can't manage their airway. Maybe they need urgent imaging or urgent medications, like if they're having an anaphylactic reaction, and some urgent procedures. So here, I thought this was kind of a realistic picture, actually, of how many people are involved when we have a pediatric pain or a pediatric trauma. You have your doctors, your nurses, your social workers, you'll have the parents in there, you'll have the trauma team, the surgeons, et cetera, et cetera. So it can get quite busy, but that's, keeps your shifts very exciting there. Okay. Before we go on to cases, I just wanted to stop and pause. Shellcast crew, are there any questions or anything so far?
Yes, we have one question about, you mentioned earlier that you guys are holistic in your care, and you mentioned you have a hand in legal work. And I was wondering what type of protocol there would be if you expect some type of child abuse, and like how often do you see that, and what are the steps for responding to something like that?
So I absolutely love your question, and I would love to get back to that because I think you're going to enjoy, or you will find one of our cases very interesting. If that's okay, we'll kind of table that discussion. But if I don't answer your question specifically, just remind me. We'll get back to it. Okay. Anything else?
On the same type of thing, it was also you mentioned interventions with like politics and like so is that just sending data or like sending reports to the local politicians, or is it we see a problem, we have to address this, we have to contact somebody in the legal system?
So I would say a mix of both. The first thing you mentioned with data and kind of seeing trends and things, that might be more for someone in like a research setting. If they find something interesting in their data, they can kind of pass it along to people who can, work on that or find actionable items for that. But we also do the latter. So even as residents, we have a group at NYU that's the child advocacy kind of track or pathway. And in the pre-COVID era, not so much recently, but anyone that's in that group or on that track actually took a day off of work and went to the New York State Capitol, where they could meet with legislators and discuss issues that were important to them. And that was kind of one of their projects they would do for residency. And just kind of an example of something that a pediatrician, maybe could put into action would be something like getting helmets to be mandatory when riding bikes, or making seatbelts mandatory, making certain recommendations on dental care, or putting fluoride in toothbrushes or in water, things like that, in addition to the more obvious child abuse, child protection type of legal things. Yeah, good question. Anything else? Are we good to go?
We're good for right now.
All right. So we're going to go through some cases. If anything's unclear, please type it in the chat so we can make sure we discuss it. Our first case, we're going to pretend that we're in the pediatric emergency room where we just left. We have, oh, that's the other thing. I kind of wrote these cases using medical jargon. I'll try to say everything out loud, but if there's anything you don't understand. Okay, so CC is our chief complaint. We have a child here who has fever for 6 days. Tmax, or maximum temperature, is 103 degrees Fahrenheit. And there's also some other symptoms over the past week. So we go see the patient, we get more history, we talk to mom. This is a young girl. She has no significant past medical history. She presents to the ED with fever. On further history, mom says, yeah, she's been a little bit cranky, but otherwise neurologically she's been normal. She's not sedated, she's not attended, she still is responding appropriately. She still is eating and drinking, but recently she's been saying, her mouth is hurting a little bit. She does complain of a stomach ache, but she hasn't had any nausea or vomiting just yet. Mom noticed there's maybe a kind of a red rash developing on her body, and that recently her cheeks have started to look redder. And then finally, the last straw was that both of her eyes turned red this morning, and mom said, that's it, that's enough, we're gonna go to the emergency room. Okay, and then just kind of for brevity, I'll include some other information. It's not as important for her. So she's been growing and developing well. She follows with her pediatrician regularly. Only other notable thing in history, mom says that she and dad both sort of had like COVID-y symptoms in February. They weren't feeling well. They had fevers, they had cough, but nobody got tested because they weren't too sick. Besides that, nothing else notable in your history. No surgeries, no allergies, no meds. Immunizations are up to date. Family, no significant history, and she does go to take. Okay, so when we're in the emergency department, I kind of like to break up our thinking into these buckets. So the first bucket is physical exam, and vital signs kind of goes along with that. So we already have our history. Now we need to examine our patient because that can really tell us a lot about what's going on. So first we get our vital signs. And we have a heart rate of 140, a temperature of 103, respiratory rate of 30, blood pressure 90/60, and oxygen saturation is 95%. And if these vitals were for an adult, we would be pretty concerned. For someone her age, I'll say they're a little bit abnormal. Heart rate is maybe a little bit fast. She, of course, has a fever. Respiratory rate a little fast. And oxygen saturation, we generally want to be closer to 100%, but 95 is not so terrible. Blood pressure is fine. Next, we move on to what does she actually look like, because this can tell us a lot. And when we go to see her, she does not look happy at all. Right away, you can see the redness in her cheeks there. And quite frankly, she does have really red eyes. We take a look at her hands and feet. And I'm not sure you're able to tell so much in this photo, but if you can see her fingers are actually a little bit swollen. And you might point that out to mom and she'll say, oh yeah, that does look a little bit more swollen than normal. And then when we're examining her skin for rash, and we see this kind of blotchy red, or what we call erythematous rash on her belly. So now we have her history, we have her physical exam. The next thing we do is, what do we think is going on? What could be causing this? How were you doing this? And when we're making that list, we think, okay, what tests do we want to run? Do we want to get any imaging? And does she need any medication? So in seeing this patient, a couple things would come to mind right away. The first for me would be infection. I'd be worried about infection. She has a fever, she has a rash, she's really not looking so well. So I would think bacterial or viral infection. Next, I would think, could this be something maybe autoimmune or rheumatologic? You certainly get fevers with autoimmune processes. You certainly can get rashes. So I would maybe be starting to think down that way. And then finally, as a future hematologist, oncologist, I always sort of have those in the back of my mind. So sometimes fever and sometimes rashes actually can be a presentation of something like leukemia. That would be much lower on my list. I would want to look into the other things first, but if we were kind of going down our differential, that would be near the bottom. Okay, so I have those there: infectious, rheumatologic, and oncologic. And now what do we want to do for her? So certainly she's in the emergency room. We can tell she's sick. Let's get some labs. So we send a whole bunch of blood. If you're not familiar, this is the way we kind of write our labs so that we know, it's like shorthand. We know where everything is, but I'll just sort of summarize what's going on with her. Ooh, I lost my mouse. Okay, so here, can you guys see my mouse here? Okay. This is called a BMP, basic metabolic panel, and it shows she's a little dehydrated, or maybe she has a little bit of a kidney injury, is what these numbers are. This here is her CBC, her complete blood count. For her age, it's pretty normal, so she's not anemic. Her white count's okay, her platelets are okay. Down here are a bunch of liver tests, and these for her age are a bit elevated, so it shows us her liver is a little bit injured or a little bit inflamed. This one, procalcitonin, is a marker that we've been using recently for a serious bacterial infection, and that's normal. So that makes us feel a little bit better. Okay, hopefully this is not a serious bacterial infection. These labs here check her heart and her heart function. And this one is actually elevated. So we're seeing that her heart, whatever's going on, her heart is affected. And then these labs here are sort of general systemic labs. All of these, I'll say, are elevated for her, and that tells us her body's very inflamed. She's having a big inflammatory response. Okay. Now, what do we want to do next? Maybe we get some imaging. She's not really telling us too much right now that makes us want to rush to like a CT or an ultrasound. Maybe because of the oxygen and maybe because of this COVID history, I might get a chest x-ray. So let's say we did. This is pretty normal. There's an arrow pointing to kind of a little bit of junk in one of the lungs, but that really doesn't tell us much. But she doesn't have like a big whopping pneumonia, for example. And finally, for medications, I would at least give her some Tylenol, maybe some fluids to help perk her up a little bit, make her feel better. Okay. Let's see what's next. So just to kind of summarize this case, we have this young girl who's had fever for 6 days. She has multiple organ systems involved. So like we said, kidneys, liver, heart, skin. So multiple. She has a lot of inflammation, and she's a child. And that's all a hint. Does anyone know what this diagnosis might be? It's okay if no. Nothing in the chat, guys?
So our YouTube stream is a little bit delayed.
Oh.
So we don't have answers right now, but
Real time.
maybe I'll give it a shot. Maybe perhaps some type of infection like you mentioned earlier, or maybe some type of organ failure.
Okay. Yeah, both of those are really good. So infection because of all the reasons we listed, right? Fever, her vital signs are abnormal. She has this rash. So that's definitely at the top of our differential. Some things that make us feel a little bit better is this number here. It's a low, which says maybe not a bacterial infection, but could certainly be viral. You're absolutely right. And then kind of a multi-system organ failure. You're definitely on the right track. I wouldn't quite call it failure just yet because they're all still functioning, but definitely multi-system organ inflammation. So I don't know if you guys have heard or if you've been watching the news for the past year or so, but we have this thing floating around called COVID. And when it first came, oh my gosh, this mystery syndrome in children, what's it called? Linked to a rare childhood illness, toxic shock, lots of alarms going off. Here we have Cuomo talking about a COVID-related illness in children. Symptoms are similar to Kawasaki disease, which is a very common illness we see in kids that's autoimmune. Then we have de Blasio come on, and he says it's a pediatric multi-system inflammatory syndrome. That is a mouthful. We shortened it to PMIS. That even got sort of corrected to something called MISC, multi-system inflammatory syndrome of children, a COVID-19 syndrome, although we don't quite call it that. Finally, eventually, the news got it right once all kind of the chaos settled down. We now have an actual diagnosis. It's called MISC. And here are some of the symptoms. So you can see our girl definitely had some. She had fever. She did have some abdominal pain. We said no vomiting just yet. She had a rash. She had swollen hands and feet. And although maybe we didn't know if her lips were cracked, she was kind of complaining that it was hurting to eat and drink. So together, this with her history and all of her labs, we would go ahead and diagnose this kind of new entity, MIS-C. So what is this exactly? As I said, it emerged out of the COVID pandemic. It's very new. The definition is always changing. The treatments are always changing. Pediatricians are learning kind of as we go how best to manage this. It does have some other names. So like I said, PMIS was another one. And to kind of make it a bigger mouthful, we have PIMS, temporally associated with SARS-CoV-2. SARS-CoV-2 is the specific virus that causes COVID-19. COVID-19 is the disease itself. Symptoms can really be anything. The key thing is that you need to have fever of over 100.4. And in general, it needs to last more than 24 hours. There are some differing definitions between like the CDC and the AAP, the American Academy of Pediatrics. But in general, you need fevers along with some of these other symptoms that you see here, and then signs of inflammation on your blood test. So that can be signs of inflammation in your liver, maybe in your kidneys, maybe in your heart. There's a whole bunch of things, a whole bunch of labs that we draw on that we trend and we make sure they get better. But really, this can affect sort of any organ system in children. So in general, most of the cases we see, oh, sorry, Nick, did you have a question?
Yeah, we do have an audience question. So you said this is a pediatric disease. Is there any specific age range of children who present with MIS-C more prevalently than others?
Yeah, that's a great question. So as you'll learn, if you hear more about MIS-C, it's very, very similar to a disease we already have that we've known about called Kawasaki disease. But one of the key features is Kawasaki disease tends to happen more in the younger kids, like 2, 3, 4, 5-year-olds. MIS-C can happen really in any age, but we're tending to see it a little bit more in the older children. And by that, 7, 8, 9, 10, sometimes in teenagers. So there's no hard cutoffs, but if you're sort of deciding between MIS-C or Kawasaki disease, the age could help a little bit, although it wouldn't, make the diagnosis.
Okay. And we did have someone else in the audience guess Kawasaki disease. So they're on the right path.
Great guess. That's awesome. You will see Kawasaki disease all the time if you go into pediatrics. And there's a ton of overlap with MIS-C. Sometimes patients that we diagnose with MIS-C actually meet full criteria for Kawasaki disease. They might just have some extra things in addition. But great guess. I'm happy to hear that. I believe I was saying in most cases, MIS-C is mild. It might just be, monitoring some labs or getting a chest x-ray, maybe a little bit of supportive care. In some cases, it can be very, very dangerous and very, very bad. If the inflammation is bad enough, it can cause bad heart injury, bad liver injury. The patient can go into shock and need to be on fluids and pressors and things like this. So that's why if you go back to kind of some of these like scary ads, that's why they were out, because the first couple cases we were noticing that the children were very, very sick. I like this one here. If your child has symptoms, call your doctor immediately. So, people were very, very worried about this at first. We still are when we see a bad case, but in general, we know that these children tend to do pretty well. So how do we treat them? Right now, we try to tamper down that inflammatory response, decrease that immune response. So we give things called IVIG, and we can give steroids as well if they need it. In addition to that, we just give supportive care. So that would be things like Tylenol, fluids. If we think they may have another infection, we can give antibiotics, things like that. And then in the more severe cases, there are some sort of experimental immunomodulatory drugs. I'm not so familiar with these. I believe most of them would be done on kind of like a clinical trial basis, or would be approved for emergency use, something like that. But we do have some treatment options, which is great. Okay, I was going to move on to our next case unless we have any extra questions. No. Okay, very good. So our second case here, Our chief complaint is we have an 8-month-old ex-full-term baby, that's what that means, brought to the ED by his mother because he's not moving his right leg for the past few days. So again, let's go get some more history. Mom tells us that on Saturday night, everything was fine, baby was perfectly normal. She put the baby down, left the baby with a babysitter, and the parents went out for a date. The next day, again, baby looked fine, but mom noticed he was crying a lot more when she was changing his diaper and when she was like, changing his clothes, things like that. On Monday, dad noticed, oh, he's not really crawling like he had been really good at crawling before. And then on Tuesday, he's crying a lot more. He's very fussy. Okay, maybe there's something with his leg. He's not really moving it as much. So they brought him to the pediatrician. They didn't think it was an emergency, but they wanted the doctor to check him out. Again, a sort of brief history. He was born full term. Oops, I'm getting a message that my internet is unstable. Is this okay?
Yeah, it's good for now.
Okay, let me know. He was born full term. He has no other medical problems, and he's never had surgery before. Again, no meds, no allergies, et cetera, nothing. On social history, we do learn he's the only child at home, and sometimes he has a babysitter take care of him. Sometimes grandma will come watch him. Okay, so we're in the pediatrician's office. What kind of things do we want to do? I approach it the exact same way. So let's go look at the baby. We have the exact same vitals here for the most part. The oxygen saturation is a bit better in this child, and I'll say for his age, they're fine. No fever, heart rate's fine, blood pressure's good, nothing to worry about. Next, we'll go to our fit, and he looks like a peach. He looks like this little cutie pie, just staring at you, very happy. He's not crying, and he's not even really afraid of you when you approach him with your stethoscope. The only thing you do know is when you're kind of trying to check his hips and check his legs, then he starts crying and gets very fussy. But when you stop, he calms down. So again, we're going to think through our differential diagnosis. What do we think could be going on here? In general, when you have sort of like one limb that you're worried about, my first thought is, could there be a fracture or a break? Is there something going on with one of the long bones, that we would surgeon to take a look at? I also think about the joints. In kids and babies, joints are prone to just having like a spontaneous bacterial infection, and that needs to be treated right away. So in this child, I might be worrying about his hip or about his knee. Maybe that's why he's not moving it. And then I think, what else are we thinking? Case where a baby is not moving symmetrically, if he's only moving one hand or only moving one leg, you worry something neurological is going on. Is there a problem with the nerves? Is it a problem with the spine or the brain? Is it a problem with the muscles? So these would sort of be the big buckets that are on my differential diagnosis list. And then in this child, what kind of things do we want to do? In our pediatrician's office, we do have a lab. We can send them for x-ray. So these things are possible. It just moves more slowly than the emergency room. In him, labs, maybe you might want to just check like a basic metabolic panel, check his calcium, see if there's any other reason that his legs or his bones or his joints might hurt. Imaging, I definitely want. I definitely do want to get an x-ray. I want to take a look at the joints, and I want to take a look at the long bones. So let's see if we can get that. Aha, here we are. Can anyone see anything that's wrong with this x-ray?
That femur is like snapped in half.
Exactly. We would call that a displaced femur fracture. And is that a good thing or a bad thing in this child?
I would consider it a bad thing.
Very bad, very, very bad. This is very concerning. This explains his symptoms. He's probably in a whole lot of pain. So in the meantime, I am going to send him to the emergency room because this needs more attention. But I'll give him some Tylenol, maybe even a little Motrin, depending on how he feels on his way down to the emergency room. Okay, so we get to the emergency room. Vitals and physical, again, the exact same. No change. He still looks like a happy, great kid, but when you try to move his leg, he's in a ton of pain. Now, what is our differential diagnosis? Now what do we think is going on since we have that x-ray? And I can ask the Shellcast crew or one of our very smart audience members who alluded to this before.
Yeah, so a lot of our audience members are saying like a fracture in the femur, you know, like what we saw in the x-ray, and yeah, agree.
Exactly. And do we have any ideas how this 8-month-old could have gotten a femur fracture if all he really does is crawl around? He's not like running or falling or anything yet.
I don't trust that babysitter.
Very good. So we call this non-accidental trauma. Good job picking up on sort of the history that baby was left with someone who, you know, maybe sometimes doesn't always care for them, or, you know, just a different caregiver. So first thing we're thinking, non-accidental trauma. Second thing we're thinking, non-accidental trauma. Third thing, non-accidental trauma. This always has to be at the top of your mind, especially if you hear anything kind of weird about the story. Certainly if you have a baby this age that, you know, the injury is not explained by anything. And even if just something kind of doesn't sit right with you, if you can't quite pinpoint it, but something seems off, trust your gut and just consider child abuse on your differential. You can never forget it. If this isn't child abuse, which we don't know yet because we haven't done our investigation, what else could it be? There are certain genetic predispositions, genetic diseases or metabolic problems that can make your bones very frail, and you can actually fracture quite easily. So something like rickets, if they don't have enough vitamin D or calcium. Something called osteogenesis imperfecta, which gives you very, very brittle bones. So these would be other things that you also want to keep in mind, because you don't want to just you know, zero in on child abuse. You need to keep your differential broad. So these would be some other things that I would think about, but certainly with a fracture that looks like that, I'm very worried that someone is hurting this baby. Now what do? We have a baby in the emergency room. We have the parents there. We think something is going on. We're going to kind of initiate this non-accidental trauma pathway. So if you do have concerns, there's a ton of things that you need to do as far as labs and as far as imaging and as far as getting help from your consulting teams, from your social workers, from your child protection advocates. Sorry, again, this is blocking. Okay. So as far as labs, I would maybe just, you know, sign up kind of the basics. We could check for some of those vitamin D deficiency, calcium, etc., so that we could rule those things out right away. Other labs that I would want would be what we call trauma labs. So if this baby's being hit on the ribs, is there liver injury? Is there pancreatic injury? Is there muscle injury? Things like that we can see in our labs. For our imaging, we are about to get a whole lot. The first thing we get, at least for our babies, is called a skeletal survey. That is an x-ray of every single bone in this baby's body, and it needs to be done by a specialized pediatric radiologist. It'll look something like this. These radiologists are trained, you know, specifically to look for fractures, both old and new fractures that can be signs of child abuse, because there's very specific sort of patterns to what fractures we look for. This is a chest x-ray that we would get as part of our skeletal survey, and these arrows here sort of give it away. But if you see these ribs, these notches on these ribs here, there's 4 here, there's 1 down here, that is very concerning for a healed rib fracture. And if you see this many, it's almost diagnostic of child abuse, you know, barring any other sort of metabolic or bone problems. And this happens when a baby is shaken. Just from the grip from the person who's doing it, they can break the posterior ribs like that. The next thing we're going to do is get some head imaging to make sure the baby's head is okay. This here is kind of a bad picture of a CT scan, but it is highlighting the bone. And if you sort of follow it all the way around, you'll see right here, we have a skull fracture. So again, that could be if the baby's been hit in the head, or if baby's been, you know, dropped, anything like that. We might get an MRI if we're very concerned. This can show us some finer detail. Here, this bright stuff would be an acute bleed, an acute subdural hematoma. And the arrow here is pointing to some bleeding inside the brain itself. So this would be very bad if we saw this. The other place to look, which you may not be as obvious, is actually the eyes, the back of the eyes. When a baby is shaken, it can affect the blood vessels in the retina. So you might see something like this. These pockets here are hemorrhages, retinal hemorrhages. And again, it's pretty diagnostic of child abuse. So we have all of these things. We're very worried about our child. Who do we call to help us? We're going to call our eye doctors because they're the ones who do these exams, especially the pediatric ophthalmologists. You know, they've done these exams many times. We're going to call the surgeons of some kind, depending on the extent of the injuries, orthopedic or trauma surgery. It might depend on what hospital you practice at. We may need neurosurgery if we have an MRI that looks like this. They may need to intervene or drain something. We definitely are going to call our child abuse pediatricians. So that is an actual field of pediatrics. It is a fellowship that you apply into when you're done with your pediatrics residency. I believe it's 3 years on its own. And you become an expert in child abuse pediatrics. We're lucky enough, we have a huge team of these physicians at Bellevue. So whenever we're concerned about anything child abuse related, 24 hours a day, we can call someone. They let us know, you know, yes, this sounds like it could be, or no, actually we see this a lot and it's probably not. They let us know what other labs to get, what other imaging to get, you know, at what point we need to get law enforcement involved, or is just contacting sort of the local children's advocates. Is that okay for now? So they really guide that. And these pediatricians, the child abuse experts, actually testify in court quite a lot in these cases. When these perpetrators go to court, the child abuse pediatricians are called as witnesses and like expert opinions, and they can comment on the imaging or kind of on the story, and they're, you know, quite useful in that regard. So it's a really, really interesting field, and it's super, super important field. Even if you don't go into child abuse pediatrics, I want you to always be thinking about this as, you know, again, if the story doesn't fit, if something doesn't feel quite right, that's just something that's not to be missed.
So, sorry to interrupt, but I just have a quick question. So like working in pediatrics, you obviously have to tell the parents like exactly what you're going to like be testing on the child. If you do suspect child abuse, do you have to like notify the parents of every single step you're doing, or do you kind of keep it in secret? And then if they ask like, why do you need these extra tests? Like, how do you go about dealing with that?
Yeah, so in general, we try to keep the family involved every step of the way, even if we are afraid that it was the mom or the dad or whoever's there. We don't keep secrets, and we certainly don't lie. It is not the physician's job to decide who's guilty and who's not. It's not our job to figure out exactly what happened. It's our job to thoroughly investigate the child and make sure that, you know, they're getting all the care that they need and that they're going to be put in a safe place. So even if it's the mother who is staying in the hospital with this child and we think it may be the mom, we're going to tell her, this is what we found. In some cases, when we see this kind of fracture, we worry that maybe someone has hurt the baby intentionally. And because of our concern for that, we need to do all of these other tests. In general, when you approach it that way, you don't receive too much pushback. I think one, because people who are innocent want you to look through everything and make sure baby's okay. And people who might be guilty don't want to seem guilty by pushing back, so they let it happen. If there's any issues as far as parents not consenting or parents trying to stop things from happening, that's when we would bring in our social workers, we would bring in our child protection advocates, we would bring in not necessarily law enforcement at that time, but maybe even hospital security, things like that, to come up with a plan to how we could best take care of this child, despite kind of having to work against the parents. But I'll say I've had a few of these cases since being in residency where we really have to admit them and work them up. And in general, there's not too much pushback. In general, we're able to finish all of the investigation that we need to do. Any other questions? Because I'm going to finish up the cases and I just have a few more points before we wrap up.
Yeah, I do have one. What effect does this have on development? I know that babies, especially, like, you know, their bodies are always working, always hyperactive. So I'm wondering if the recovery is faster from, like, let's say a bone break, or like, I know the brain can adapt well, but just seeing these injuries, they seem so severe and such a, vulnerable person. I just have to wonder, like, what does it do to their development?
How they do. Great question. And I will say, it's a bit unsatisfying, but it completely varies. So as you said, kids are super, super resilient, which is one of the things I love about peds. So their bones are always growing and turning over. Eventually, if we go back to the grid picture here, as this baby grows, the fractures will not always be there. So they will kind of heal over as the baby gets bigger. Even with these crazy brain bleeds, if it doesn't require intervention, sometimes the body can just sort of resorb the blood, and it fills in with like extra CSF, extra fluid. Based on this image, could I tell you how the baby's going to do? No, definitely not. It all depends. It's really up to the baby and up to kind of the medical intervention. There are kind of services for victims. If we notice that their development is falling off, we can get what's called early intervention. We can make sure they're getting the physical therapy, the speech therapy, whatever it is, to support them as much as possible. But just seeing the kid right there when you're worried about it, you're not able to say how they're going to do, unfortunately. Good question. Okay, I'm going to move on just so we do have a little bit of time at the end for audience questions if we want. Okay. Oh, person who asked the child abuse question before, did I answer all your questions about that?
Yes.
Okay, absolutely.
Thank you.
Okay, I was asked to share a little bit about my personal journey, why I wanted to pediatrics and why I want to do peds hemonc. There was a lot of reasons I kind of came up with. I always tried to keep my options open, but I just kept going back to peds. It was just the rotations I enjoyed the most, the patients I enjoyed the most. And I found that the things I really liked about it was that you get longitudinal care. So you get to see the patients right now from when they're babies and they're growing. In pediatric hemonc especially, you will be taking care of them for years of their lives. You will become basically their new primary care pediatrician. So I love kind of forming those relationships and sort of getting to know the family really, really well. I like that you can take care of all aspects of their health, their physical health, their mental health. It's obviously quite complicated in peds hemonc, and that's one of the things I love about it. And then I also like when I get to see my patients nice and healthy and happy and they're in clinic and they're in the outpatient setting, but also when they're really, really sick and they're in the hospital, I get to take care of them in both settings. You get to do that in general pediatrics, and you get to do that especially in peds hemonc. But even with all of that, this is why I want to do peds hemonc. It's these patients that have stuck with me. So Nick was my hemonc patient I knew in high school. Gigi in London, we're in college. Val in med school. Myra, Miles, these are my patients. They're like the ones that will stick with me forever and ever, that have left the biggest impact on me and my training. And there's something special about that when you have that relationship. It's what I know I want to do with my life. What life is like as a pediatrics resident outside of work, so family, social, personal. I will say it doesn't matter if you're in peds, no matter what residency you go into, this is one of the most important things. Work is important, but your life is important too. You need to make time to see your family. I'm lucky enough, mine live in New York and New Jersey, so I get to see them quite frequently. And it's so important for me. Socially, I find I'm hanging out with my coworkers a lot just because we're sort of on the same type of night day schedules and things like that. And then personally, it's so important to take care of yourself. I do this by working out, I do this by baking and cooking and things, but it's really, really critical that you're able to take care of these other aspects of your life while working. Just some final advice. I like to say, follow your passion, not your paycheck. For me, peds hemonc, I think, is like the second lowest paid specialty ever in the world. But I know that if I was doing anything else, I would not be happy. Some people will go into medicine for the paycheck. Obviously, the surgical fields, the procedural fields get paid a lot. If it's not your passion, you will not last. Medicine is not an easy road to take. It's not always nurturing. It's not always fun. And if you are not passionate about what you do every day when you wake up, you're just not going to last. It doesn't matter how much money you make. My second tip is that mentorship matters. So as you're going through undergrad, and especially as you're going through med school, identify your mentors that you're working with, whether it's a professor, whether it's an attending that you're shadowing, whether it's another resident that you really admire. Foster those relationships and keep them, because they will come in big handy in the future. You know, you can learn from them. Like, that's the kind of doctor I want to be. That's the kind of researcher I want to be. That's the kind of person I want to be. And really stick with those. It's so important. And I feel like it's not something that's really emphasized enough. And then again, just to make it clear, my most important advice, please take care of yourself. You are not able to care for others if you are not well. And, you know, studying for the MCAT, applying to med school, applying to residency takes a toll. It really takes a toll. You'll start to see it in your classmates, if not in yourself, in the next few years. So start early, take care of yourself, whether it's meditation or exercise or some kind of sports outlet or talk therapy, whatever it is, you need to take care of yourself before you can take care of others. And that, I think, is one of the most important lessons at this stage in your career. With that, I'm done. I'm happy to take questions. Please be in touch if you have any questions that you don't want to say on this stream here. Here's my email. And let's see, is there anything in the chat?
We do have a few questions. The first is, pediatrics is unique because you're dealing with a patient that you can't really communicate effectively with. So we have a question is, how do you, fill in that gap? Obviously you have labs and the parents, but you don't have that valuable piece of information coming from the source.
Absolutely. Great question. This certainly applies, especially like when we're in the NICU or dealing with our newborn babies. It's hard. It's certainly hard. There's a lot of uncertainty. We do a lot by our physical exam. One of the first things you'll learn when you go to residency is to determine sick or not sick. There's certain things to look at: how they're breathing, what their skin looks like, and kind of what their pulse or their fluid status is. Just by those things, you can start to get an idea, okay, sick or not sick. If they're not sick, but there's still something going on, with our little babies, you need to just keep a broad differential. You need to think outside the box. You need to think what is most likely, what would be the worst thing to miss in this patient. There are, for the little ones, certain like scoring systems. So based on things like vitals and physical exam, shaking or high tone, whatever it is, we can score them and sort of give them a pain score to sort of try to assess in an objective manner. But it's definitely tough in the little guys. In kind of more the toddler age, they may not be able to perfectly tell you like, oh, it hurts me right here and it feels like stabbing pain. You kind of learn, you learn the pediatric talk almost. Especially as you see your patients more than once. You know what's normal for them, you know what's not normal for them. And trust your physical exam. Physical exam can tell you so much when your patient really can't. And I guess on top of that, trust your parents, because your parents can tell you a lot when your patient can't.
On top of the have you ever faced an issue, or how do you deal with issues of parents disagreeing with treatment plans or disagreeing with like medicine and stuff like that? Like, we've been hearing a lot about like anti-vax and like a lot of that stuff, and like parents do know their child better and they feel like they know what's best for them, but sometimes they don't even have the correct information. So how do you deal with situations like that?
This is a huge part of pediatrics, I'll say. When people who aren't in peds, when you tell them you want to go into it, they're like, oh, but you have to deal with the parents. Isn't that the worst? In general, no, it's lovely. Dealing with families is amazing. Certainly, you have your times when the parents are just not on the same page as the medical team. First, I would say we try to partner with them. We try to understand where they're coming from, what their understanding of their child's illness is, what their understanding of the treatments are. And we do try to fill in those sort of educational or knowledge gaps, like you said, if they're just completely misinformed. If that doesn't work, we try to kind of offer other options. So for example, we want to give this medicine, but you want to give this medicine. What if we try this one for the first few days, and if it doesn't work, then we can try your idea. So you sort of try to align with them that way. If they really will not let you do something, sometimes it happens and you have to, you have to go with the parent. However, I will say, if you feel that a child's life is in danger, or that serious harm will happen to a child if they don't receive the care that you're recommending, you do have the right to give that care. The parent is not allowed to what we call AMA. If you guys have heard this, they're not allowed to check their child out of the hospital against medical advice. That's like basically them saying, yeah, I'm listening to the doctors, but I don't care what they say. I'm bringing my child home. If the pediatricians feel that this is a life-saving treatment, or that the child will experience significant harm if they do not receive this treatment, we can actually administer it. Sometimes it takes a whole bunch of social workers and security guards, and sometimes we have to go to the ethics committee. So it can be quite a battle. But our job is to take the best possible of the child. And if the parent agrees, even better. In some instances, if the parent disagrees, we still have to do it. It's really tough. It's a fine dance, but it's really interesting cases.
Thank you so much for coming. We don't want to take you above your time, but I want this to keep going. Thank you so much for presenting all your cases. And to the audience, we dropped the quiz down below. Please take your time and answer those questions thoughtfully, because she did go over a lot today and brought up a lot. And just again, make sure to join our listserv so you don't miss anything, our LinkedIn and our Instagram. All the links are in our Instagram bio and our Linktree. We thank you again for coming, and we hope you guys have a good rest of your day.
Thanks, guys. Take care.